Hello, everyone, and welcome to today's webinar, Trauma Verification's December Q&A web conference. For best sound quality, we recommend that you join audio through the telephone. If you are listening through your computer speaker system, simply open your control panel and select telephone in the audio pane. The dial-in information is then displayed. I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you. Thank you, everyone, for joining today's webinar. So I'm just going to introduce myself. I'm going to run today's webinar by myself. Rachel and Tammy are out. Just some housekeeping things that I'm going to let you guys know. Continuing education. To qualify for CE, you must attend at least 50 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar and webinar ending with instructions on how to claim CE. If you have any questions regarding your CE or during the webinar, or of any questions we presented or any things that we presented, please email us at cotvrc@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient Manual to ensure that hospitals have an understanding of this criteria to provide quality care to the injured patients, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patients at your center. So let's go ahead and get started. As many of you are familiar, you do need a copy of the Orange Book, either hard copy or electronically. Be sure that you are using the most current clarification document and change log. Below is the link to access those. Again, many of you have joined us before, but if you're new to our process, we note any clarifications on the actual clarification document, and any changes that were made to a standard are going to be noted in the change log. We do not reprint the book, so there are no updated versions of the actual manual, as some folks have said. Again, I just want to let everyone know we just released a copy of the clarification document for through November, the end of November. So we just released it this past week, or this past Friday, I believe it was. And we did make a change to this, and I'm glad to know that one person did catch that change. And the change is that we have shortened the document to only display those standards that have a clarification. So as you may have known before, we had basically listed all 380 plus criteria on this document that was like about 90 pages long, and we've condensed it or shortened it really to only display those that have a criteria or clarification. So you will see that going forward, that's how the document is going to be displayed. There's no change to the change log. We didn't have any updates for that, so that, but we will post a more current one on the website as well. Recordings of the webinars during the webinars are recorded during the session and will be posted within 1 week of the ACS on the ACS YouTube channel. You may access those through the link noted there, and you will also find past recordings going all the way back to June 2016 of all our webinars. And one of the things that we're going to look into doing is posting the PowerPoint presentations along with those recordings, so they'll be easily accessible. Currently, you only will have access to the recordings, and if you want a copy of those slides, you certainly can email us, and we will send you copies as far back as we have them, which is June 2016. So we are going to look into possibly providing copies of all those presentations online for you guys. Disclaimer, all questions are pulled directly from the questions that are submitted through the portal. There have been no edits, so you may see some typos or some really shortened questions, and I've become a master at ciphering questions. If you have any questions, if your question is not answered during today's webinar, it's possible that it's a duplicate question and we're going to cover it in one of the slides, or it is also possible that I am gathering more information and will send you a response separately. And it is also possible that I may need to follow up with you to get more details. Some announcements, and I may go through these a little quickly because some of them are redundant, and I do want to let everyone know that we do look at everyone's comments following our webinar. So there were some concerns that things were kind of repetitive for the first 20 minutes of our webinar. So if I do go through them quickly, it's because I know some of you know this information, but I know there's some new folks on the call that may not know this, but you can certainly go back through the web PowerPoint and look at that information. So the next webinar is going to be hosted on January 25th, 2018. The deadline to submit questions will be January 11th, 2018, and our webinar time will be at noon Central Standard Time. Just a quick update on the resources revision process, and I will spend a little time on this because this is really what I've been working on a lot lately, but just to let everyone know, again, this website is open and will remain open for, I don't know, probably forever as far as we're being told. And again, if there's any concerns that you may have or want to see a change in something, make sure that you do visit that website and give us your feedback. Just an update, Chapter 6 has been completed. 7 and 8, we're still kind of waiting to assemble the team. They have not kicked off yet. Chapter 9, 15, and 19 have kicked off with their team leads. So those work groups are currently working on reviewing what is currently written in the chapter and looking at your comments that you've provided us. Chapter 10 pretty much is, I hate to say the word done, but it is pretty much reconciled already. So we're just looking to make a final pass on that and work with the team leads on that. So hopefully that'll get approved. I'm thinking possibly March. I don't think we're going to make the January deadline, but hopefully we're looking possibly at March. Just some resources for trauma program managers and trauma medical directors. These are on our web pages, so please, you know, if you're new to our process, take a few minutes to just familiarize yourself with our website. The resources website is the one that's most commonly used. Just some scheduling reminders. I don't know if a lot of you know, we have merged with TQIP, and DRC has merged, so we're called the Trauma Quality Program, the TQP, and we developed a hub, as you see here, and basically this is kind of like your portal to access, you know, if you're a new program, you're going to join a program, but if you're an existing trauma center, you should have received logins, and you can certainly access your accounts and establish a primary contact and your registrar, and you can also submit data and download reports. But one of the things I want to address here is, and we're kind of encountering this now, at least my team is, myself, Megan, and Booney, is that if there is staff changes in your program, and I realize that you're submitting an application 14 months ahead of time versus, you know, 2 months ahead of time, but you're submitting it 14 months ahead. And I do realize that things can happen within 14 months. We are well aware of that. And, but I really want to stress how important it is for you to update that information on your account center page. The reason being is that we're encountering some challenges in having the correct staffing when we're ready to release the report and the letter. So if you are the primary contact at your facility and your predecessor has left, you will need to access that account center. So you'll have to email the TQIP team at tquip@facs.org to get some logins. Site visit application, as I just mentioned, we're 13, 14 months ahead of scheduling. meaning if you're looking for a visit next year, if it's not in November or in December, it's not going to happen until 2019. So Rachel has a few openings in November, and I believe she said December is still available. So again, if you're a new center looking to have a site visit, whether it's consultation, verification, or re-verification, just make sure that you get your application in time. I do want to mention that if you're a trauma center that needs a focused review, an on-site focused review, we honor, basically, we don't follow the schedule. I should put a slide together for that, but we don't follow this 13, 14-month lead because trauma centers who have required on-site focus, they have a very limited time of when they have to correct that or address their deficiency. So we will honor the time frame you give us. So just make sure you submit that application shortly after your site visit if you need a focus review. Again, I talked about this, and I just want to just make mention of a couple of things that we kind of just noticed as we're looking at our processes. We do review our processes. We do our own internal PI process. And one of the things that I do want to mention, and I don't think we've mentioned this before, but on the site visit applications, we realized that we did not have a spot for combined trauma centers and having the pediatric teams information noted on there. So I do want to ask you, until we revise that application here shortly, to allow some room so that if you are a combined trauma center, you enter your pediatric teams information on there. And also the other thing we want to mention is to also add your credentials if you're an RN, PA, NP, EMT, whatever your credentials are, to go ahead and put that in there. Again, these are things that we've just been encountering lately as we're finalizing reports and letters, that people do move on and take on new roles, and the new trauma program manager is just fairly new, within a month or 2 months, and we just don't have that contact information because no one's let us know. So again, it's just a little challenging for us when we do prepare the letters and reports. We send it out and then we have to kind of revise it as we go along. So, and the other piece of this is that many of you who have been through the process or have just recently gone through a site visit, Megan and Boomy are the ones who are really processing the reports. And one of the things they do is they're looking at, even though you have the review team on site, they are also looking at the report and the PRQ to ensure that everything is in compliance. So then if there's tables, as many of you know, those tables are a little tricky to fill. So if they need information about the tables or something's missing in your PRQ, having the most up-to-date contact information is very helpful to the team, because otherwise, it will delay your report if we don't have the appropriate contact. Because I know sometimes it's, going through the trauma medical director can take some time. So just want to make mention of that. The orthopedic trauma leader form, as many of you know, if you are a level 1 trauma center, just make sure you're submitted a form with that. And the form is on the website, as you see below. One of the things that we are working on is revising the OTL form. We are now going into we're just finishing actually our first review cycle with the Orange Book. So going into 2018 now, it's kind of going to be a little repetitive for some of you. So if you have already submitted an OTL form, and there was no change to your orthopedic trauma leader, there's no need for you to resubmit that form. However, we do, or you may get an email from someone on my team or from Anita asking who your OTL leader is or if there was a change. So we're going to update the application to ask the question whether or not there was a change. And if there's not a change, just give us their name and we're just going to verify that information. But there's no need for you to resubmit another form. But for new trauma centers who have not undergone this, you must complete a form. Alternate pathway, again, just real summary. If you have a non-board, if you have a site visit coming up, just make sure that all your providers, surgeons, and physicians are board certified. They're current in their boards. If you happen to have someone who trains abroad, overseas somewhere, and they're not boarded here in the United States or in Canada, they can qualify under this alternate pathway process. And there is a process to this, and we do need the information ahead of time. So make sure that you visit our website and download a copy of that information. PRQ, again, just a summary. Upon a receipt of your application, you will get access to your PRQ, online PRQ that is. So a lot of questions that we triage have to do with, I don't have my logins. Please go back to the acknowledgement email that you received from Anita Johnson or Rachel Sanchez, and the email and your logins will be noted at the bottom of that email. So you'll have to scroll quite a bit to get to that. But if you don't have your logins, or there's been staff changes and you want a new logins, we certainly can do that as well. So just go ahead and email us. Site visit application, again, many of you know this, not to submit a payment with it. You will be invoiced for your annual fee that includes verification and TQIP. So, and those are generally done, I believe it's quarterly. Don't quote me on that, but you certainly can email us at cotvRC.facs.org if you haven't received an invoice for some time now. Scheduling processes, as you know, they're usually scheduled within 90 days. Sometimes, as you may have heard, they're sooner. Sometimes we run into some challenges, or I should say Rachel runs into some challenges. So just know that even though you're submitting the application 13, 14 months ahead of time, you know, she's working on those, and it does take some time to schedule the teams for these. But I think I had reported last month that she is trialing a pilot where she is has kind of reached out to a few trauma centers to kind of narrow down the date to 2 dates really, or 2 sets of dates, you know, if it's December 1st and 2nd or December 15th, 16th, and that's what we're going to work with. So it's just a trial. It's in the trial phase right now, and we're hoping that that may work better for a lot of programs. This way you guys can plan ahead and secure the team members that you need and the room, and get things in order by having a firm date. So again, she is piloting that, and hopefully we'll have more information to come in the next couple of months. This is just an overview of preparing your site visit with the reviewers. Just make sure that for those of you that have a visit coming up, make sure that you are received information from Rachel and who your contacts are, and you have that information, and just reach out to them. You don't have to be too specific. Just, you know, introduce yourself, tell them that, you know, you're the trauma program manager, and if there's anything they need, ideally, you know, most of them will ask to be picked up from the airport and kind of driven to their destination. So just, again, just make sure you reach out to them, and if they need additional accommodations, you are only required to accommodate for one, make arrangements for 1 night, but if they need additional nights accommodation, ACS will pay for that, and make sure you contact Rachel and let her know that that may be a possibility. Again, just you know, reach out to your reviewers and just let them know who you are, and if there's anything they need, any dietary restrictions or anything like that, or if you're preparing for your case reviews, you know, if you're electronic, make sure you're asking them if there's anything in addition that they would need. As I mentioned, the clarification just went out, and I just want to touch on that real quick. I know there was some folks that we were getting some emails that just weren't, they felt it wasn't clear enough. So one of the clarifications was the post-traumatic stress disorder. This was a question actually that came up during the Pediatric Trauma Society, so I'm just circling back to close the loop on this. This is noted in Chapter 12, and it is not a requirement. I repeat, it's not a requirement. However, centers should develop a plan to evaluate, support, and treat PTSD as part of your rehab program for the injured patients. And one of the questions that was asked is, does acute stress screening count as PTSD screening? And it does. So if you're a trauma center that is also screening for acute stress disorder, definitely it counts towards the PTS screening as well. And that is noted in the clarification. And again, I'm going to circle back around on the universal alcohol screening. We've had a lot of questions about this, and the chairs feel strongly on this. The question that had come up is, does this include ortho or neuro? Because it does add another, it adds volume to the process, and we realize that. And again, I strongly encourage you to visit our website to let us know about the stakeholder website, that is, to let us know that this is adding more time to your staff, and you may need more resources. So for level 1, 2, and 3 trauma center, universal screening for alcohol must be performed on all injured patients that meet NCDS trauma inclusion criteria, obviously with some exceptions, with a hospital stay of greater than 24 hours, of which we're stating it's not 100%, we're stating that 80% of those patients must receive a screening, and it does again include ortho and neuro. And I think a question had come up about whether it was only for activation patients, and it's not, it's for all patients. All right, we're just going to move along. So questions about hospice patients. Are patients disposed to hospice review counted as a death for peer review and PI purposes from a level 1? And this will be true for any level. For verification purposes, and you'll see this through my webinar that I will always say for verification purposes, a living patient discharged to hospice should not be counted as a death. It's not a death. This should be captured in your transfer numbers and reviewed with all other transfers. Information concerning the patient after their passing, you know, if you've discharged into a hospice and you're lucky enough to get information back from that facility, you certainly can enter that into your registry just to close the loop on that patient. Locums, use of locums 2 to 3 days a month for general surgery and neurosurgery. What is locums attendance requirement for peer review? Regardless of the frequency of using locums for coverage, if they are treating trauma patients, even if you have them once a month and they're covering your trauma service and they're seeing trauma patients, they are required to meet the same standards or requirements as the other trauma panel members. This will include being current in their board certification, if they're a trauma surgeon or if they're a neurosurgery, CME, whether that's internal, external, peer review meetings, and that's just for trauma surgeons, and they also must undergo OPPE process review. General surgery backup call schedule. Can general surgery attendees, I think that meant attendees, cover as trauma on call backup, providing he has ATLS and has trauma experience in the past? So I'm taking this to mean that can general surgery cover trauma and vice versa? And the answer is yes. It is acceptable as long as the general surgeon has been given privileges at your facility and has been credentialed at your facility. And credentialing is defined by each individual institution, and that could be ATLS, that could be their training, it can be CME, etc., to provide backup to the trauma service. These instances should be monitored through the PIPS process. Actually, it must be monitored through the PIPS process. If the general surgeon is occasionally put on the trauma call schedule, similar to locums, to provide coverage, they are required to meet the same requirements as the other trauma panel members. So there's a distinct difference here. So if they're strictly just providing backup, we don't have any standards on that because they're just your backup general surgeons. But if they're on your call service or put on there occasionally, once a month, twice a month, or just by happenstance, they're going to be treated like locums. They're going to have to meet the same requirements. Will the resources guide be released as chapters are updated, or are you waiting until all are completed? We're going to be waiting until all chapters are completed. So we're not going to release as a chapter is updated and approved. That's not going to get released. So once everything is released, once all the chapters have been updated, then there's going to be a predetermined time frame. Right now, I may be, I don't know, January 2020, 2021, 22. We're going to give trauma centers a year for those that are pending a review the following year post-release of the book, just to implement those changes if there are any that they need to implement. What is the recommended ratio for number of trauma patients to social worker for trauma level 1 pediatric trauma centers or level 1 adults? So I think that's a great question, but we really don't have any standards on this. We don't have a requirement for the number of trauma patients assigned to a social worker. So that is going to be defined by the institution if that's how it's set up at your shop. PRQ question, inclusion criteria for hip fractures. I thought this was a good one too. In a previous webinar, hip fractures were not reported in the PRQ unless they were required by state to be reported. In the past webinar, it was stated that they should be reported. Reporting hip fractures and including them in the PRQ will add hundreds of hours of work to our abstractors. I'm concerned about whether they should or should not be included. So hopefully my answer will help this person. And basically it comes down to if the patient, so these patients may not be required based on your state or hospital admission inclusion criteria. So if these patients are not part of your admission inclusion criteria, they are not to be reported in the PRQ. So again, so if you're in a state that does not require you to capture those patients, then, and you're not going to use that as part of your admission inclusion criteria and not use them in your PRQ totals, then that's really your decision not to enter those in your registry or use them in the PRQ. However, for verification purposes, if you are in a state or at a hospital that includes those patients as part of your admission inclusion criteria and are entered into the registry, and you will be using those patients to complete the data collected PRQ, then they are to be reported in the PRQ. So just a slight difference there. So if they're not required by your state or your hospital, then you don't have to capture those. But if they are and you're going to use that data, or they may not be required, but you're going to use that data to complete your PRQ, then you do want to report that. PRQ, next verification following a focus visit. So this question has to do with completing the PRQ, and there is a couple of questions that ask, when was your last site visit, or the date of your most recent site visit, what deficiencies were identified, what weaknesses, etc. So this person had a question about filling that out, and they had received a deficiency and then had a follow-up focus review, and whether or not they need to enter all that information in the PRQ. So for the PRQ, we're asked to list the most recent visit deficiencies and weaknesses, list the date of the focus visit. So if you had a focus visit and everything was resolved, that is what we want you to note. Do not list the CD because it was resolved, so technically you didn't have any, and only list those weaknesses that were not related to the deficiency. List only those deficiencies that you're kind of working on still, or you're still making improvements on. Trauma centers that have not undergone an ACS review, basically have never gone an ACS review, or maybe there's like a 10-year gap or 15-year gap, do not list your state visit as the last visit. Keep all those blank. So again, just wanted to clarify that. Transfer agreement. Is a transfer agreement a legal signed document between two entities or an informal agreement in hospital procedure? It is a legal document. You're transferring trauma patients, so you definitely want to have this as a formal and legal document signed by the two entities. Transfers, could you please clarify what is considered transfer? You mentioned ER to ER, but also about freestanding clinic and our PCP offices included, especially if they call a report to the receiving facility. We did get some questions on this, and I do want to state that there are some slight differences between what verification is considering transfers in versus what PQIP is considering transfers in. So I'm not going to cover what PQIP is considers transfers in. That's more of a data collection point and a data submission aspect, and Amy was going to cover that in her webinar. So I'm going to cover the portion for verification. So for verification purposes, a transfer from another facility, regardless if it's under one license or not, such as a hospital, trauma center, freestanding satellite ER, and or from a primary care physician's office, are considered interfacility transfers. There's like transfers in for us for verification. So when you're completing your PRQ and you're pulling cases, and we're asking you to pull cases, transfer cases, this is exactly what we want to see. We want to see an interfacility transfer. So someone is coming to your facility from another destination, even if it's from your campus. We want to know who is coming in, and those are technically considered transfers in. And also, in addition to this, all transfers must be evaluated as part of the receiving trauma center's PIPS process. That is a requirement. So, and any feedback should be provided to the transferring center. So again, that's not the last part is not a requirement. It's a should, but the requirement is that you must be reviewing your transfers as part of your PIPS process. Trauma program manager, please elaborate on the amount of time a level 3 trauma program manager may devote to other responsibility of their job descriptions. Again, this is a level 3. I want to make sure, because a 1 and a 2 is different than a level 3. So a level 3 trauma program manager is not required to be dedicated and or full-time at a trauma center. The time allotted to his or her role will be based on their responsibilities, such as, is the trauma program manager also acting as the registrar? Is that person also the PI coordinator? Are they doing injury prevention? Are they doing something other than what's in trauma? One of the things that has to be taken into consideration is the volume of trauma patients at level 3 is seen. Some of them can be as high as a level 1, and some of them are pretty low. So again, these are all the things that have to be taken into consideration so that as not to hamper his or her duties as a trauma program manager. Even though it's not full-time, or we're saying it doesn't have to be full-time, these additional responsibilities will impact their performance. And if it does impact their performance and during a site visit, it may be cited as a weakness. So I just caution this person to be careful on how many tasks they're overseeing. We had a question about a corrective action plan template, and I thought this was a good idea, and I think we're going to add this to our project list. Why isn't there a standard format for corrective action plans that are to be submitted 30 days prior? So some of you are not aware of this, because if you've never had to undergo a focus review or had to or encountered a deficiency, a trauma center who has been found with deficiencies, we ask for a corrective action plan and how they've addressed that deficiency, whether it's going to be an on-site focus or focus by mail. So we don't have a template for this, and we leave this up to the institution to kind of design it. And basically, it's just a Word document that tells us a summary of what was their finding, or a summary of what was cited, and then how they addressed it. So, and most trauma centers will develop their own, because the deficiencies and weaknesses will vary. So, and how they want to explain that to us. But as I said, I think we're going to add this to our ongoing project list and develop a standardized corrective action plan template. So we'll have more to come at a later date. Our nurse practitioners and physician assistants assigned to trauma service and participating in the resuscitation of acute trauma patients required to meet any specific CME standards similar to that of their attendings and subspecialist colleagues. In addition, are they required to meet the peer review attendance of 50%? No. So nurse NPs, PAs, APPs, mid-levels, we use all those acronyms a little similar, kind of similar. There are no CME requirements for them. If they're seeing trauma patients, no CME and no peer review attendance requirements for them, whether they're on the activation team or assigned to the trauma service. So this was, so I got permission to share an example of a tracking ICU kind of like what this particular trauma center is using. So I did get permission from them. So during the September 2017 webinar, there was a question about, and I actually have gotten this question many times before, but I didn't have a sample, and this person was kind enough to send me one, on how to track trauma surgeons' response to the ICU. So again, this is just one example. So per the trauma program manager that sent this, the sheet on the following slide is copied and placed in a binder. The sheet is given to the charge nurse in the ICU who is responsible for completing it and returning it to the trauma program manager. This then demonstrates that the surgeon is responding timely to their pages. The trauma program manager then collates, I think that should be collates, the data into a log and graph to demonstrate compliance for the on-site review team. Again, this is just an example. So there was a sheet. So she gave me a sheet. So there was like 5 of these on one sheet. So I just kind of snipped it and just put 2 on here. But you can, if you need a copy of this, you can email us and we'll share this with you. But basically what she does is she just uses this sheet to document or gives it to the charge nurse, and the charge nurse is the one who enters or fills this out, and then this then is given back to the trauma program manager, and then she kind of tracks it and logs it and does a compliance report for the review team, or at least for her PI process at least. So if you want a copy of this, please go ahead and email us at the cotvrc@fscs.org, and we'll have this available for you. Just going to move on. We just have a few questions on CD related. Trauma program manager, CD 523. The Orange Book states that the trauma program manager must be full-time and dedicated to the trauma program. As I mentioned, level 1, level 2, different than a level 3. They have to be dedicated and full-time. Does this mean the trauma program manager cannot take on other responsibilities within an organization, such as, and this is what kind of confused me a little bit because it's its title, Director of Trauma Program and Critical Care Units. It sounds like this particular trauma center has other dedicated coordinator resources, 3.5, and are available within the program. There's a PI coordinator, outreach, education coordinator, etc. So let me say this. This sounds like it's a high volume trauma center, and again, the resources, the staffing resources are going to vary based on the trauma center and overall. The expectation is that the trauma program manager is dedicated to the program, to the trauma program, and not have oversight of other programs such as emergency department or possibly another program such as the children's surgery program, etc. The trauma program manager titles will vary among all trauma centers. So we don't have a specific job title that we want the trauma program manager to have. So I have seen many that say Director of Trauma Service or Director of Trauma Program and Critical Care. We get the title. Now, the key point of this is that the job description must ensure that the responsibilities for the trauma program manager are under the scope of the trauma program and not necessarily say that they're going to cover trauma program and the ER. So that's where it may get a little tricky, and it may cite a deficiency, because ideally we want the level 1 and level 2 trauma centers for their trauma program managers to have oversight over just the trauma program. It just becomes too much of a duty to have oversight over two services. So again, key point is that the job description must ensure that the responsibilities for the trauma program manager are under the scope of the trauma program and are not encumbered by additional duties that fall under another service. So I think that was a great question. And I will say this, and I didn't add this to the slide, that there are some programs that do have a Director of Trauma Program and Critical Care. That's okay, but they also have another level where they have a trauma program manager that does cover the trauma program itself. So that is an acceptable thing to do. So if you have a Director of Trauma Program, but you also have another trauma program manager under you that reports to you, that is also acceptable to do. I know we've covered this quite a few times. Can a trauma senior resident respond at bedside for neurotrauma activations? Consult the neural attending within 30 minutes and documents it. The practice is acceptable. The intent is that the trauma medical director and neurosurgeon liaison develop guidelines for which types of critical and complex injuries the neurosurgeon will respond to in person within 30 minutes time frame. So that could be either let me just continue. If they send the PA or APP or the resident, that's where I was going to go with this, there must be guidelines that speak to this and clear documentation that there was a discussion with the surgeon specialist on the plan of care. So basically, if the neurosurgeon liaison has developed guidelines for what types of injuries he or she are going to respond to, and they may be on the complex side and then send the resident for the less complex injuries, again, they can do that within 30 minutes. That's acceptable. We've said this. It's in the clarification document. This is true for the ortho as well. So again, it is acceptable as long as there are some guidelines established that says which ones the neurosurgeon is going to do and which ones the residents are going to do within a 30-minute response time. Trauma surgeon must retain responsibility. So we had a question about the responsibility piece. And again, I may follow up with this person a little bit more, but my understanding is, does the ACS have recommendations on who has the ultimate responsibility for patient and decision-making in the operating room? So CD 1158 talks about the responsibility and oversight of the trauma surgeon. So if the trauma patient is under the care of the trauma surgeon, and she has not signed care over to another service, then ultimately the trauma surgeon has the responsibility of that patient. But if they're in the OR and it's with the neurosurgeon and the trauma surgeon, they have to work collaboratively. So I don't know if there's more to this, but if there is, if this person's on the webinar today, please email me if there's more information on this that I can help with. ICU patient to nurse ratio relating to standard 1166, the patient to nurse ratio in ICU must not exceed 2 to 1. Is it okay to have 4 to 1 if the patients are designated as ward status? We have a shortage of acute care beds, so sometimes ICU patients awaiting transfer to the floor are designated ward status while waiting for an acute care bed. The typical nurse to patient ratio on the ward is 1 to 4. So, you know, there's really no there's no way around this, to be honest with you. It's in the book as 2 to 1, and that's what the reviewers are gonna look for. So if the ratio exceeds this, they're gonna cite it as a deficiency or possibly a weakness. If they cite it as a weakness, it is possible it gets elevated to a deficiency. So I just want to caution the person who submitted this question. So the patient-nurse ratio must not exceed 2 to 1. This is defined as for every 2 ICU patients, there is a minimum of 1 nurse. So if there's 10 ICU beds, there should be 5 ICU nurses taking care of the 10 patients. ITLS for advanced practice providers. If ED-APPs only care for non-trauma activation injured patients, are they required to maintain a current ATLS certificate? So the way I read this, and it may differ, but the way I read this is that these are non-trauma activation injured patients. Kind of like an oxymoron if you say activation and non-trauma. So maybe may be a typo, but if the advanced practice providers are solely seeing and treating non-trauma activation injured patients, such as those that come in for a consultation or through fast track, are not required to be current in ATLS. It would be ideal, but it's not a requirement. The reason I caution on activation, the word activation, is because if they are a member of the activation team, as many of you know, if they're a member of the activation team, that is your red alert, we call them level 1 alert or level 2 alert, and their resuscitation, participating in the resuscitation efforts, they are required to be current in ATLS. Research alternate pathway. For level 1 research article requirements, do review articles count? So they do. They do count for and I don't know if a lot of you know, there's 2 pathways to the research requirement. There is the 20 published articles that a level 1 trauma center has to meet. And then there's an alternate pathway, which is 10 research articles plus 4 basically it reads 4 out of the 7 scholarly activities can be met in addition to the 10 research articles. And on page 145 under item number 2 of the alternate pathway method, it's under 2B and it's the 3rd bullet, I believe. It says evidence of dissemination of knowledge and includes review articles, book chapters, technical documents, web-based publications, videos, editorial comments, training manuals, and trauma-related education materials or multi-center protocol developments. Those are all acceptable. So if that meets one of the 4 out of the 7, great. Research for combined programs. We are currently a level 2 adult and level 2 pediatric combined center. We will be seeking verification as a combined level 1 adult and remain as a level 2. So basically it's a level 1, a combined level 1 with a level 2 pediatric trauma center. My question is about research. Will an article or case study of a pediatric topic count for adult trauma center since there is no research required for a level 2 pediatric trauma center? Yes, it will. So I thought we had a number for the combined centers for a level 1 and a 2, but we did not have a number. But yes, it may count for the research alternate pathway. So I just want to make that clear. In a combined level 1 adult and pediatric trauma centers. You may have a combination of adult and pediatric research articles in addition to case studies as well. So you can have a combination of both. We just have a couple of CME questions. CME from board certification proof. Is proof of board research sufficient enough evidence for the 33 allowed CMEs for board certification? It is. The surgeon or physician has to give you a copy of their board certification. I don't know if they'll give you a certificate copy, but that definitely would suffice. But I think, and I'm not 100% sure, but I think it may also be on their transcript as listed as board certification. So you can use their transcript if it's listed on there, or if they have a copy of their or a letter that they recertified. Those are both acceptable to provide proof. Please clarify the difference in claiming trauma CME for initial board certification versus recertification. So there is no difference, at least not for us, for the college or for the VRC process. Trauma-related CME for either the initial board certification or recertification may be claimed to meet the requirement at least once during the 3-year verification cycle leading up to the site visit. So, and I pretty much know it's going to happen once during the cycle, but I just wanted to make that clear. So there's no difference in either one of those. CME, how do you calculate the 3-year time frame for CME? Does one of 3 years include the year you are surveying? So here's the straight answer. A total of 48 hours of external trauma-related CME over a period of 3 years leading up to the site visit must be acquired. This can be obtained by having the providers obtain 16 hours annually. So every year they'll accumulate 16 hours to get to their 48 hours. We're not saying that you have to do 16 every single year. If you have a provider that is super short, maybe just did 3 hours and needs to make up the rest of the 43 hours, I think there's a couple of programs out there they can do it overnight. Where it can be a rolling year, it just really depends on when your survey is. So if you are doing a visit, say in September, that's already 9 months into the year, you want to get as close as you can at least for CME, that is, get as close as you can to your site visit. You don't want to do the past 3 years from September's site visit, because then it kind of puts you out too far. So again, it's 48 hours within 3 years leading up to your site visit. I thought this was a good question. Will the CME requirements be going away? No, unfortunately, it's not. I know there was a lot of talk about this, that, you know, it may go away, but unfortunately, we've gone through our first revision, or actually 2 revisions right now, chapters, and it's not going to go away, sadly, but the focus is to make it easier on trauma programs, and one of those easy ways may be just doing it through the maintenance of certification, and that's what we are looking at. This way, you know, it's really going to be the trauma surgeon and the providers to maintain that, because they have to maintain their MOC for their board. So that is one of the ways that we're looking at making this easier for trauma programs and not have to collect certificates. So more to come on that. We're still kind of working on this. And as of right now, the MOC is one of the pathways that we're looking at making CME compliance. But it is not going to go away, sadly. So that is going to conclude our webinar today. I want to thank everyone for joining us, and I want to wish everyone a happy holiday.
Thank you, trauma verification staff, and thank you everyone for attending today's webinar, Trauma Verification's December Q&A web conference. If you have any other questions, please contact cotvRC@facs.org. On behalf of Trauma Verification and our presenters, thank you for joining us, and have a great rest of your day.